Hi, my name is Laura, and welcome to my audio version of the Emergency Medicine, Obstetrics and Gynecology EOR Study Guide. The rest of the emergency medicine topics can be found on my channel, but I'll link them below as well. This review is going to follow the PAEA Obstetrics and Gynecology portion of the Emergency Medicine End of Rotation Exam topic list, and I'll timestamp all the topics below in case you'd like to skip around. The first topic is amenorrhea, which is the absence of menstruation. This can be broken down into primary and secondary amenorrhea. Primary indicates that the patient has never had a menstrual period before. Primary amenorrhea refers to a lack of menstruation by the age of 15. Secondary amenorrhea indicates that the patient has menstruated before, but has not had a period for at least 3 months. More specifically, if the patient previously had normal cycles, we call it secondary amenorrhea after 3 months. But if the patient has a history of irregular cycles, we call it secondary amenorrhea after 6 months. Primary amenorrhea has a few different etiologies, including outflow obstruction like an imperforate hymen, Müllerian agenesis, androgen insensitivity, Turner syndrome, or HPO axis abnormalities, such as in extreme athletes, anorexia, or certain illnesses. Depending on which condition is suspected, diagnosis can be made by pelvic exam, hormone levels, and karyotype. Now on to secondary amenorrhea. The number one cause of secondary amenorrhea by far is pregnancy, so always check a pregnancy test on these patients. One of my professors likes to say that if they are a female of childbearing age, they are pregnant until proven otherwise, so do a beta-HCG pregnancy test first. The other common causes of secondary amenorrhea are hypothyroidism and prolactinemia. So if the pregnancy test is negative, check TSH and prolactin. If TSH is high, this indicates hypothyroidism and can be treated with levothyroxine or Synthroid. If prolactin is high, an MRI can be done in order to assess for prolactinoma, which is treated with a transsphenoidal resection. Now, if the pregnancy test is negative and the TSH and prolactin are normal, and the patient history and physical don't indicate any nutritional disorders, extreme exercise, or systemic diseases, then we need to assess the hypothalamic pituitary axis. The first step is a progestin challenge to induce bleeding. The test is positive if menstrual bleeding or withdrawal bleeding occurs within 2 weeks after the progestin is given. If bleeding occurs, this means that the patient has estrogen present, is able to build up a uterine lining, but is not ovulating. Anovulation is most commonly due to PCOS, or polycystic ovarian syndrome, which is a condition involving hyperandrogenism, irregular periods, infertility, insulin resistance, and sometimes obesity. If the progestin challenge fails to induce bleeding, the next step is an estrogen progestin challenge, similar to the previous step, but with estrogen added. If bleeding still does not occur, the problem is with the uterus itself, meaning the uterus is not capable of bleeding. This is typically due to Asherman syndrome, which is an acquired endometrial scarring that can be secondary to an overly vigorous DNC, ablation, endometrial infection, etc. If the estrogen progestin challenge does induce bleeding, the amenorrhea is due to hypoestrogenism, because estrogen was needed to induce that bleeding. To determine the cause of hypoestrogenism, check FSH and LH. If these hormone levels are high, the problem is in the ovaries, and an ultrasound is needed to assess whether there are follicles present in the ovaries. No follicles indicates menopause. Many follicles indicates Savage syndrome or resistant ovaries. And lastly, if FSH and LH are normal, the problem is not with the ovaries, and the next step is an MRI of the brain to look for something wrong in the anterior pituitary or hypothalamus, such as a tumor or Sheehan syndrome. The next topic is dysfunctional uterine bleeding, and this refers to excessive or prolonged bleeding or bleeding outside of the regular menstrual cycle. It's typically a diagnosis of exclusion, and it's most commonly secondary to anovulation. The acronym to know for the etiologies of uterine bleeding is PALM-COIN. PALM represents the structural causes and stands for polyps, adenomyosis, leiomyoma, and malignancy or hyperplasia. COIN, spelled COEIN, represents the non-structural causes of uterine bleeding, and it stands for coagulopathy, ovulatory dysfunction, endometrial causes, iatrogenic or illness-related, and N is not yet classified. We'll go through this acronym briefly here, but the women's health videos go into much more depth. First is polyps. These are growths attached to the inner wall of the uterus that extend into the uterine cavity. A is adenomyosis, which is an extension of endometrial tissue within the myometrium, or the muscular layer of the uterus. L is leiomyoma, or uterine fibroids, which are benign smooth muscle tumors. M is malignancy and hyperplasia, since abnormal uterine bleeding is the most common symptom of endometrial cancer, but it can also indicate endometrial hyperplasia. Now we're into the non-structural etiologies, starting with coagulopathy. Von Willebrand's disease and platelet dysfunction are the most common coagulopathies associated with uterine bleeding. O is ovulatory dysfunction, which describes a patient who is not ovulating or has infrequent or irregular ovulation. This can be caused by conditions of androgen excess or hypothalamic pituitary adrenal, or HPA, axis dysfunction. Androgen excess is found in conditions like PCOS, androgen insensitivity, and androgen-producing tumors. HPA axis dysfunction includes conditions like hyperprolactinemia, thyroid disorders, Cushing syndrome, congenital adrenal hyperplasia, ovarian follicle decline, lactational amenorrhea, tumors or trauma to the pituitary or hypothalamus, intense exercise, stress, or starvation, and finally, there's premature ovarian failure. Okay, E is for endometrial, which is usually due to a primary disorder of the endometrium. I is iatrogenic causes, in which the bleeding is attributed to medical devices like IUDs, gonadal steroids, especially progesterone-only preparations, or drug therapy like anticoagulants or dopamine antagonists. And finally, N stands for not otherwise classified and encompasses a variety of rare and poorly understood conditions. To diagnose dysfunctional uterine bleeding, make sure to get a full history from the patient, reconcile their medications, and rule out pregnancy. Consider labs like FSH, LH, prolactin, estradiol, testosterone, TSH, T3 and T4, and coagulation labs. Then evaluate the uterus, especially via pelvic ultrasound, but an endometrial biopsy might be warranted as well. Treatment is dependent on the particular diagnosis. The gold standard for dysfunctional uterine bleeding due to a structural cause is a dilation and curettage, also referred to as a D&C. This is therapeutic and can also help diagnose the specific etiology. Other surgical options include endometrial ablation and hysterectomy. Oral contraceptive pills are also commonly used to regulate the menstrual cycle, and NSAIDs can reduce menstrual bleeding as well. The next topic is pelvic pain and dysmenorrhea. Dysmenorrhea is defined as painful menstruation and is broken down into primary and secondary. Primary dysmenorrhea has no associated pelvic pathology. It's due to increased prostaglandin and leukotriene production, which cause painful uterine muscle activity. Secondary dysmenorrhea, in contrast, is due to pelvic pathology, such as endometriosis, adenomyosis, PID, tumors, adhesions, and the list goes on. Dysmenorrhea commonly occurs right before or with the menses in the suprapubic or pelvic region. It generally lasts 1 to 3 days and may be accompanied by headache, backache, nausea, and vomiting. Treatment is based on the underlying cause, but in general, first-line treatment is NSAIDs because they inhibit prostaglandin activity in the uterus. Hormonal contraceptives can be prescribed as well to suppress ovulation and significantly reduce symptoms. If these medications fail, a laparoscopy can be done to assess for secondary causes. The next topic is ovarian cysts.
An ovarian cyst is a fluid-filled sac within the ovary. They're common in reproductive years, typically harmless and asymptomatic, and most spontaneously resolve within a few weeks. Most women have no idea they're even there unless there's a complication, like the cyst ruptures, causes ovarian torsion, or becomes hemorrhagic. In these cases, the predominant symptom is unilateral lower quadrant pain, depending on which ovary has the complication. There are two different classifications of ovarian cysts: functional, meaning they're a variant of the normal menstrual cycle, and non-functional. Non-functional cysts include dermoid cysts or teratomas, and endometriomas, also known as chocolate cysts, as well as cysts associated with polycystic ovarian syndrome or PCOS. Functional cysts, considered normal variants, can be divided into three types. The most common functional cyst is a follicular cyst, which occurs when a dominant follicle in the ovary fails to rupture and continues to grow instead. The next type is a corpus luteal cyst, which occurs when a dominant follicle does rupture, but then closes again and doesn't degenerate after ovulation. The last type is theca lutein cysts, which are only seen with pregnancy. They develop due to overstimulation of beta-HCG, which causes hyperplasia of the theca interna cells, resulting in a cyst. And again, out of these three types of functional cysts, follicular is going to be the most common. Diagnosis is made by pelvic ultrasound of the ovaries, which will also rule out ovarian torsion. Also order a beta-HCG to rule out pregnancy. And a serum CA-125 can assist in ruling out ovarian cancer. An ultrasound-guided aspiration can also be done for histologic analysis and definitive diagnosis. Management is supportive. Most cysts less than 8 centimeters are functional and will resolve spontaneously. No follow-up imaging is even needed if the cysts are smaller than 5 centimeters. If they're larger than 8 centimeters and persistent or found post-menopause, then MRI or laparoscopy might be warranted. There are a few complications that can occur with ovarian cysts. The first is ovarian torsion, which is the rotation of the ovary at its pedicle to such a degree that blood flow is obstructed. Ovarian cysts greater than 5 centimeters are the biggest risk factor for this condition. Diagnosis is made by ultrasound with Doppler, which typically shows obstructed Doppler flow. And treatment is laparoscopic surgery to untwist the ovary and restore perfusion. The other complications of ovarian cysts occur when the cyst ruptures and/or becomes hemorrhagic. Remember in the normal menstrual cycle that the rupture of follicles happens with every ovulatory cycle. Typically, these follicles are less than 3 centimeters in size, and for many women, these don't cause any pain. In fact, when they do cause pain, it's referred to as Mittelschmerz, pain with ovulation. So pain from a ruptured ovarian cyst can vary greatly based on the patient. Fluid from a ruptured cyst can leak into the intraperitoneal space, which can cause pain or irritation. But serous fluid from a simple cyst is not typically as irritating as blood from a hemorrhagic cyst, which can accumulate in the ovary or flow into the abdomen and irritate the visceral peritoneum. So while each patient's pain level will be different, a hemorrhagic cyst tends to be more painful than the rupture of a simple cyst. Next is endometriosis. This is the presence of endometrial tissue outside of the uterus, most commonly in the ovaries, fallopian tubes, posterior cul-de-sac, broad, and uterosacral ligaments. This extrauterine endometrial tissue responds to menstrual hormone changes just like uterine endometrial tissue. So patients often present with premenstrual pelvic pain and the 3 Ds: dysmenorrhea, dyschezia, and dyspareunia, so painful menstruation, defecation, and intercourse. It can also present asymptomatically in about a third of patients. History of infertility is also common. A pelvic exam is often normal, but the uterus can also present as fixed and retroflexed, or there might be tender nodularities of the cul-de-sac and uterine ligaments. Definitive diagnosis is made by laparoscopy with biopsy. Imaging tests are not adequate or specific enough for diagnosis, so you actually have to visualize this extrauterine endometrial tissue. It appears as raised patches of thick, discolored scar tissue, or it can have a powder burn appearance. Sometimes endometriosis involving the ovaries gets large enough to be considered a benign tumor, usually filled with old blood, giving it a chocolate appearance. This is called an endometrioma or chocolate cyst. Treatment begins conservatively with NSAIDs, and the patient can be offered hormonal birth control for ovulation suppression to treat premenstrual pain. In more severe cases, leuprolide and danazol can be used to suppress FSH and LH. And lastly, surgical options include laparoscopic endometrial tissue removal by ablation, which conserves fertility, or hysterectomy. Next is vaginal discharge, which can include a variety of causes. The differential diagnosis should include yeast infection or candida, bacterial vaginosis or BV, sexually transmitted diseases like chlamydia, gonorrhea, and trichomonas, or foreign body like a tampon. We'll go through a lot of these in the next topic, but it's important to do an STI check and pelvic exam on these patients. The next topic is vaginitis, or inflammation of the vagina, which can be caused by trichomonas, bacterial vaginosis, candidiasis, or atrophic vaginitis. Here, I'm just going to go through this list in order. So trichomonas is a sexually transmitted infection characterized by pear-shaped flagellated protozoa. Men are usually asymptomatic, but women present with vulvar itching, erythema, dysuria, postcoital bleeding, and copious amounts of frothy yellow-green vaginal discharge. The hallmark pelvic exam finding is cervical petechiae, which is called strawberry cervix. Diagnosis is made with a wet mount that shows mobile, pear-shaped protozoa with flagella. Another important clinical point for trichomonas is that vaginal pH will be greater than 5. Normal is 4 to 4.5. So for treatment, metronidazole or Flagyl, PO, is the drug of choice, and it's safe in pregnancy. Like with many other STIs, the partner must also be treated so that it's not passed back and forth between them. Next is bacterial vaginosis, more commonly known as BV, and this is the most common cause of vaginitis. This one is not an STD though. BV occurs when a decrease in lactobacilli, which normally maintain the vaginal pH, allows for an overgrowth of normal flora, especially Gardnerella vaginalis. Patients are often asymptomatic but can present with a vaginal odor or pruritus and a grayish-white, fishy-smelling discharge. Diagnosis is made by presence of clue cells, which are epithelial cells covered by bacteria, as well as the decrease in lactobacilli. Vaginal pH will be greater than 5, and a wet mount of the discharge with a KOH prep produces a fishy odor, which is referred to as a positive whiff test. First-line treatment of BV is metronidazole or Flagyl, and second line is clindamycin. Because this is not an STI, there's no need to treat the partner. Since both trichomonas and BV are treated with the antibiotic metronidazole, I wanted to do a quick review here. Metronidazole has only anaerobic coverage, especially below the diaphragm anaerobes, which is why it's first line for these conditions. Trichomonas and Gardnerella are both anaerobes. When prescribing this antibiotic, you have to advise the patients not to take it with alcohol. When combined, metronidazole and alcohol have a disulfiram-like reaction that causes flushing, tachycardia, palpitations, sweating, headache, acidosis, nausea, and vomiting. So advise patients to avoid alcohol during treatment and for 3 days following completion of this antibiotic. So next on the list is candidiasis, also called a yeast infection. And this is another incredibly common cause of vaginitis, especially in diabetics, pregnancy, steroid use, and patients taking antibiotics. This is a fungal infection caused by overgrowth of Candida albicans. It presents with vaginal and vulvar erythema, swelling, burning, itching, dysuria, and a clumpy white discharge often compared to cottage cheese. Vaginal pH remains normal, but diagnosis is made by presence of hyphae, or yeast on KOH prep. Treatment is oral fluconazole, but you can also use intravaginal or topical antifungals as well, such as clotrimazole, nystatin, or tioconazole. Last is atrophic vaginitis, or vaginal atrophy. This condition is associated with menopause and results from estrogen loss as females age. It causes the vaginal tissues to become dry, thin, and inflamed, leading to discomfort and irritation as well as painful intercourse, recurrent UTIs, and urinary incontinence. Vaginal atrophy is a clinical diagnosis made on vaginal exam, which will show thin, pale mucosa. Treatment should start with a non-hormonal vaginal moisturizer or lubricant, but topical estrogen creams tend to be more effective. Oral hormone replacement therapy is also effective if there are no contraindications. The next topic is pelvic inflammatory disease, or PID, which is an infection that ascends to the upper portion of the reproductive tract, meaning the endometrium and/or fallopian tubes. A number of different organisms can be responsible for this, but most commonly, the causative organisms are gonorrhea and chlamydia. Patients with PID present with pelvic or lower abdominal pain, fever, dysuria, pain with intercourse, nausea, vomiting, and purulent vaginal discharge, sometimes bleeding. Pelvic exam often shows positive chandelier sign, which is cervical motion tenderness to palpation, often so severe that the patient is said to jump as if reaching for the chandelier. Diagnosis is primarily clinical. The patient must have abdominal tenderness, cervical motion tenderness, and adnexal tenderness, plus one or more of the following: fever, white blood cell count greater than 10,000, pelvic abscess or abnormality on bimanual exam or ultrasound, positive gram stain of culture, increased ESR or CRP. Additionally, laparoscopy, if done, can provide a diagnosis as well. Treatment is divided into inpatient and outpatient. Outpatient treatment is doxycycline with ceftriaxone, plus or minus metronidazole. You can kind of think of this as covering the common organisms: doxy for chlamydia, ceftriaxone for gonorrhea, metronidazole for anaerobes. If the patient is severely ill, has nausea and vomiting, or another complicating factor, consider inpatient hospitalization. Inpatient treatment is IV doxycycline plus a second-generation cephalosporin like cefoxitin or cefotetan, or they can get clindamycin plus gentamicin, as long as their renal function is normal. Finally, pelvic inflammatory disease can cause a number of complications due to infected abscesses and development of scar tissue. These complications include infertility, ectopic pregnancy, chronic pelvic pain, tubo-ovarian abscess, and Fitzhugh-Curtis syndrome. Now on to ectopic pregnancy. This is the implantation of a fertilized egg somewhere other than the uterus. In 98% of ectopic pregnancies, the implantation site is within the fallopian tube, most commonly the ampulla, often due to occlusion of the tube from adhesions. Other potential sites are the ovary, cervix, or even abdomen. Risk factors for ectopic pregnancy include pelvic inflammatory disease, previous abdominal or tubal surgery, history of tubal ligation, endometriosis, IUD use, assisted reproduction, and previous ectopic pregnancy. The classic triad to remember for ectopic pregnancy is unilateral pelvic or abdominal pain, vaginal bleeding, and pregnancy or amenorrhea. Cervical motion tenderness or an adnexal mass might be present as well. If it's a ruptured or rupturing ectopic pregnancy, there might be severe abdominal or referred shoulder pain, peritonitis, nausea, vomiting, and signs of hemorrhagic shock like tachycardia, hypotension, and syncope. A ruptured ectopic pregnancy is a true medical emergency. Diagnosis is made with serial quantitative beta-HCG and transvaginal ultrasound. The beta-HCG should double every 24 to 48 hours in normal pregnancy, but it won't increase this much in an ectopic, and it might even plateau or decrease. Ultrasound can confirm the presence or absence of pregnancy within the uterus. And when beta-HCG is greater than 2,000, but there's no gestational sac on ultrasound, it strongly suggests ectopic pregnancy. Treatment of an unruptured ectopic pregnancy is methotrexate. If the patient is hemodynamically stable, in early gestation, with beta-HCG less than 5,000 and no fetal heart tones, then methotrexate is given to destroy the trophoblastic tissue. If there's a contraindication of methotrexate, a laparoscopic salpingostomy or salpingectomy can be done. If the patient is unstable or has a ruptured ectopic pregnancy, first-line treatment is laparoscopic salpingostomy to remove the ectopic tissue. In this procedure, a hole is created in the fallopian tube in order to access the ectopic gestation, so sometimes a reparative procedure is also needed to save the reproductive organs. A salpingectomy, or removal of the fallopian tube, is an option too, as is a laparotomy in severe cases. And also administer RhoGAM if it's indicated. The next topic is intrauterine pregnancy, so let's go chronologically from the first signs of pregnancy to labor. Confirmation of the pregnancy should be done by beta-HCG in a blood or urine sample. Some other indications of pregnancy include Hagar, Chadwick's, and Goodell's signs. Hagar's sign is the softening of the lower one-third of the uterus. Chadwick's sign is the bluish discoloration of the cervix, vagina, and vulva due to increased vascular congestion. And Goodell's sign is the softening of the cervix in pregnancy. Also, if you remember them in this order, Hagar, Chadwick, Goodell, then their initials spell out HCG, which is the confirmatory test for pregnancy. Once pregnancy is confirmed, we can predict the estimated date of delivery using Nagel's rule. It's calculated as the first day of the last menstrual period plus 7 days minus 3 months. So if the first day of the patient's last menstrual cycle was December 13th, 2021, we add 7 days, making it December 20th, and subtract 3 months, making it September 20th. Then don't forget to add a year. So the estimated date of delivery would be September 20th, 2022. While this is a good calculation for the exam, the most accurate estimation of gestational age is the crown rump length, measured from the first trimester ultrasound. Fundal height can also provide an estimate of gestational age. At 12 weeks gestation, the fundus of the uterus should be palpable at the pubic symphysis. At 16 weeks, it's midway between the symphysis and the umbilicus. At 20 weeks, the fundus is at the umbilicus. And then after 20 weeks gestation, the fundal height in centimeters corresponds to the week of gestation. For example, at 30 weeks gestation, you should measure a fundal height of 30 centimeters. Patients should be following up with an obstetrician for their pregnancy. If they're getting prenatal care, some of the labs that should be done at the first visit include CBC, blood type and Rh factor, blood glucose, hepatitis B, HIV and syphilis screening, rubella titer, and screening for sickle cell and cystic fibrosis. A urinalysis should also be done to assess for glucose and protein in the urine. During the first trimester, which is weeks 1 through 12, the patient gets their first trimester ultrasound. This confirms intrauterine pregnancy, estimates gestational age, gives a heads up to any potential complications, and fetal heartbeat can be heard via ultrasound by 6 weeks. Other tests that might be done in the first trimester include screening for trisomy 21, which is Down syndrome, trisomy 13, and trisomy 18, which is Edwards syndrome. During the second trimester, which is weeks 13 through 27, the patient should experience fetal movement, also called quickening. This typically happens at 18 to 20 weeks in first pregnancies, and then a little earlier at 14 to 16 weeks in subsequent pregnancies. Screening tests that can be done in the second trimester include the triple or quadruple screen and amniocentesis. There's also an ultrasound in the second trimester referred to as the anatomy scan. This is the one that everyone looks forward to because it reveals the sex of the baby. But a lot of other measurements of fetal anatomy are done here too. It also screens for short maternal cervix length, which has an increased risk of preterm birth. Patients are also screened for gestational diabetes via the glucose challenge test, and Rh-negative moms get their first anti-D immune globulin injection, also called a RhoGAM shot, at 28 weeks. The second RhoGAM injection is given within 72 hours of delivery. Now we're into the third trimester, which is week 28 until delivery. During this trimester, the patient gets swabbed for group B strep. If they're positive, the mother simply gets IV antibiotics during labor to prevent group B strep in the newborn. Other tests that might be done during the third trimester include a non-stress test or even a full biophysical profile to assess fetal well-being. These might be done more often in higher risk patients, especially in the cases of gestational hypertension or diabetes, post-term pregnancy, intrauterine growth restriction, or to assess decreased fetal movement. Now, a few more general points on normal intrauterine pregnancy. The average weight gain during pregnancy should be 20 to 35 pounds, with an increase in calories of 300 extra per day. And the patient should be taking prenatal vitamins that include folic acid and iron. During pregnancy, the patient should avoid smoking, alcohol, and drugs, and they should also avoid unpasteurized foods like apple cider and soft cheeses, raw meat and seafood, and deli meats due to the risk of listeria. And avoid king mackerel, swordfish, tuna, tilefish, and shark due to high mercury levels. And lastly, a quick review on the stages of labor. The first stage is defined as the onset of labor until the patient is fully dilated to 10 centimeters. The second stage is from full dilation to the birth of the baby. And the third stage is after baby is born until the delivery of the placenta. The next topic is Placenta Previa. Placenta Previa and Placental Abruption are the two most common causes of third trimester bleeding. So Placenta Previa is a condition in which the placenta implanted very low in the uterus and is covering part or all of the cervix. This occurs in about 1 in 200 pregnancies. It can be complete, covering the entire cervical os, partial, covering a portion, or marginal, within 2 centimeters of the os. Placenta Previa is characterized by sudden onset of painless third trimester bleeding. There's no pain or tenderness with this bleeding. There's usually no fetal distress either. Risk factors include increasing age, multiple gestation, and smoking. Diagnosis is made by pelvic ultrasound to locate the placenta, and sometimes diagnosis is already known prior to any bleeding episodes due to routine ultrasounds. Also, do not perform a pelvic exam in these patients as it can provoke hemorrhage if palpated. Treatment is modified bed rest, so no vigorous activity, as well as pelvic rest, so no intercourse. Tocolytics might be used to inhibit uterine contractions and prevent preterm labor. Steroids can be given to aid fetal lung maturity in case delivery occurs early. And a C-section is a preferred route of delivery since the placenta is literally blocking baby's exit. And then Vasa Previa is a similar condition in which fetal vessels lie over the cervical os. Rupture of membranes causes painless vaginal bleeding as well as fetal bradycardia, indicating fetal distress. So presentation is third trimester painless bleeding and fetal bradycardia. And treatment for Placenta Previa is an immediate C-section. Placenta Previa and placental abruption are the two most common causes of third trimester bleeding, so let's go over placental abruption now. It's defined as the premature separation of some or all of the placenta from the uterine wall after 20 weeks, resulting in painful hemorrhage. Placenta abruption presents with third trimester bleeding, often dark red, and often severe abdominal pain with uterine contractions. The uterus can be rigid, abdominal pain might extend to the back, and the patient might present with symptoms of shock, although it's possible to be asymptomatic as well. Additionally, fetal bradycardia indicates fetal distress because baby's oxygen supply is being disrupted. Risk factors include trauma, hypertension, preeclampsia, multiple gestations, cocaine, and alcohol abuse. The diagnosis is always clinical, and again, do not perform a pelvic exam. Ultrasound might show retroplacental blood collection, but is generally not that helpful. Other signs include fetal bradycardia and uterine activity. Treatment of placental abruption is hospitalization and immediate delivery, preferably C-section. Corticosteroids can be given to aid fetal lung maturity, if indicated, and type and screen is indicated in case the mother needs blood products. Additionally, as many as 10% of cases might develop DIC, disseminated intravascular coagulation. The next topic is premature rupture of membranes, commonly referred to as PROM, and this is defined as the rupture of membranes at 37 weeks gestation or later, but prior to the start of uterine contractions. Now, PPROM, or preterm premature rupture of membranes, is when the membranes rupture before 37 weeks gestation. Risk factors of PROM are smoking, STDs, prior preterm deliveries, and multiple gestations. So the patient will present with a sudden gush of clear or pale yellow fluid from the vagina. Diagnosis is made by confirming that this fluid is in fact amniotic fluid. First, on speculum exam, you'll see pooling of secretions. Then, a nitrazine and/or Fern test can confirm it's amniotic fluid. A nitrazine paper test will turn blue if the pH of the fluid is greater than 6.5, meaning that PROM is likely. And under a microscope, the fluid will develop a Fern pattern when it air dries. This ferning is the crystallization of the amniotic fluid, a positive Fern test. The major complications associated with premature rupture of membranes are infection, like endometritis, and umbilical cord prolapse. So treatment involves hospitalization and induction of labor, depending on the gestational age. For PROM, meaning the patient is at 37 weeks or more, simply await spontaneous labor. For PPROM, induce labor if the pregnancy is greater than 34 weeks. If it's less than 34 weeks, assess fetal lung development, consider steroids and antibiotics, and then induce. The next topic is fetal distress. The well-being of baby is monitored by fetal heart rate, and a Doppler ultrasound is used to assess this. Normal fetal heart rate is between 120 and 160 beats per minute. If it's higher than 160 for more than 10 minutes, it's considered fetal tachycardia. And if it's below 120 for more than 10 minutes, it's considered bradycardia. A non-stress test, NST, can be done as well to record fetal heart rate along with fetal movement. A healthy reactive NST will have 2 accelerations in a 20-minute time period And these accelerations are defined as an increase in fetal heart rate of at least 15 beats per minute for at least 15 seconds. Anything less than 2 accelerations, or even fetal decelerations, is a non-reactive NST. It's possible that baby is just sleeping though, so vibroacoustic stimulation can be done, and then repeat the NST. If that fails, a contraction stress test can be done. This is similar to an NST, but uterine contractions are induced using a low dose of oxytocin in order to measure fetal response to contractions. An acceptable or negative contraction stress test will have no late decelerations or significant variable decelerations in the presence of 2 contractions in 10 minutes. A positive contraction stress test will have repetitive late decelerations and indicates fetal distress. Prompt delivery is recommended at this point. And the acronym for interpreting NSTs and their etiologies is VEAL-CHOP. This is probably important for exams. So VEAL stands for variable decelerations, early decelerations, accelerations, and late decelerations. These are all the possible results of the NST. CHOP refers to the causes of these results. CHOP stands for cord compression, head compression, O is okay, and P is placental insufficiency. So the V in VEAL corresponds to the C in CHOP, and the E corresponds to H, and so on. Variable decelerations on NST are caused by cord compression, often the baby's head on the umbilical cord. Early decelerations are caused by head compression, like the baby's head descending into the pelvis. Accelerations are okay, meaning they're a normal, healthy sign. And late decelerations, more worrisome, are caused by placental insufficiency. The next topic is spontaneous abortion. Spontaneous abortion, or miscarriage, is an expulsion of all or part of the products of conception before 20 weeks gestation. The incidence of spontaneous abortion is at least 15 to 25% of all pregnancies, and 80% of those occur in the first 3 months. By far, the most common etiology is fetal chromosomal abnormalities, which are responsible for about 50% of all spontaneous abortions. Other risk factors include smoking, maternal infection, uterine defects, endocrine abnormalities, malnutrition, trauma, and drug use. If spontaneous abortion is suspected, order an ultrasound to assess fetal viability, quantitative beta-HCG, CBC, blood type, and antibody screen to determine if the patient needs a RhoGAM injection. Treatment is based on what type of spontaneous abortion is occurring. Threatened abortion means that the pregnancy might be viable, or miscarriage might occur. It presents with bloody vaginal discharge, either spotting or profuse bleeding, and possible contractions, but with a closed cervix and no products of conception or tissue expelled from the uterus at this point. Treatment is supportive, rest at home, monitor beta-HCG to see if it's doubling. And threatened abortion occurs before 20 weeks. All of these actually occur before 20 weeks. Inevitable abortion means that the pregnancy is not salvageable. It presents with moderate bleeding for more than a week, moderate to severe cramping, progressive cervix dilation more than 3 centimeters, but no fetal tissue expelled at this point. Treatment for inevitable abortion is a suction curettage in the first trimester or a dilation and evacuation in the second trimester. Also give RhoGAM if mom is Rh negative. An incomplete abortion is also not a salvageable pregnancy. It presents with heavy bleeding, moderate to severe cramping, a boggy uterus, dilated cervix, some tissue expelled and some still retained. Treatment for incomplete abortion is a D&C in the first trimester or a dilation and evacuation in the second trimester. Or the patient may just be allowed to continue expelling tissue if they're progressing sufficiently. Pitocin can also be given, and a RhoGAM shot should be given if it's indicated. Complete abortion means complete passage of all products of conception from the uterus. At this point, cramps and bleeding have usually subsided, and the cervix is closed again. The only treatment at this point is a RhoGAM shot if the mother is Rh negative. A missed abortion is when fetal demise has occurred, but all the tissue is still retained in the uterus. Symptoms of pregnancy loss might be present, as well as brown discharge, but the cervix is still closed. Treatment for a missed abortion is similar to an incomplete abortion. The patient gets a D&C in the first trimester, or a dilation and evacuation in the second trimester, as well as misoprostol, which is a prostaglandin that causes uterine contractions. A septic abortion occurs when retained fetal tissue becomes infected. Symptoms include foul brownish discharge, fever and chills, spotting or heavy bleeding, uterine tenderness, cervical motion tenderness, but with a closed cervix, and some or all of the products of conception retained. Treatment is a dilation and evacuation to remove the infected tissue, plus broad-spectrum antibiotics. In severe cases, a hysterectomy might be necessary. The last term to know here is recurrent spontaneous abortions, and this is 3 or more consecutive pregnancy losses. The last topic is mastitis and breast abscess. Mastitis refers to inflammation of the breast, often from a blocked milk duct, but can also be from bacteria, either from skin flora or the oral flora of a breastfeeding infant that enters through trauma to the nipple, like cracks in the skin. This causes unilateral erythema and tenderness, and Staph aureus is the most common culprit. Treatment is predominantly supportive with warm compresses and analgesics. The mother should continue to breastfeed from the affected breast, as this helps to prevent congestion and does not pose any risk to the baby. Finally, anti-staphylococcal antibiotics might be required, and the first line is dicloxacillin. And if you have trouble remembering this one, just think of how we describe breast anatomy, like clocks. Palpable mass at 9 o'clock. Well, dicloxacillin is for diclox. Other antibiotic options for staph are cefalexin and erythromycin. A breast abscess is just a pocket of contained infection within the breast, and is generally a progression from mastitis. The symptoms are the same, but with a palpable abscess and sometimes signs of systemic infection, like fever. Again, Staph aureus is the most common pathogen. Like with mastitis, these patients get anti-staphylococcal antibiotics, such as dicloxacillin, as well as an IND, incision and drainage. And at this point, breastfeeding does have to stop, but only from the affected breast. And that wraps up the obstetrics and gynecology portion of the Emergency Medicine EOR Exam Study Guide. And thanks for sticking with me on this one, especially since I'm getting over a cold at the moment. If you're listening to these videos in order, the next section is psychiatry and behavioral medicine, which I'll link below once it's up. If you're listening as these videos roll out, there's a whole lot of EOR content getting uploaded at once, so stay tuned, subscribe to the channel, and thank you so much for listening. Happy studying, and I'll see you in the next video.